Hello everyone. We're going to talk about age-related bone loss and osteoporosis. I am Nahid Rhiannon. I am an assistant professor in the Division of Geriatrics and Palliative Medicine at the University of Texas Medical School at Houston. Our learning objectives for today. Attendees will recognize osteoporosis and related fractures as important public health problems of old age. Attendees will understand the pathophysiology of age-related bone loss. Attendees will be able to calculate fracture risk in geriatric patients and treat osteoporosis with an individualized plan for each patient. And attendees will be knowledgeable about prevention of age-related bone loss and related fractures. So why osteoporosis? Osteoporosis is a state of our bone health where we increase the risk of fracture. And the most common consequence of osteoporosis is fracture that can decrease quality of life by causing pain. And pain can be due to the compressed abdomen, as you see in the picture on the right-hand side, around 40 years of age, how upright we are. And as we increase age and we have osteoporosis-related vertebral fractures, we have a stooped stature, and that can compress our abdomen. As you can see, the rib cage almost touching the hip bone, which can also cause a chronic pain. It can decrease functional mobility, spinal cord deformity, and of course, depression. And the risk of vertebral fracture goes even higher after the first one, about 5 to 20% risk of a recurrent vertebral fracture. And after a hip fracture, about 50% of the patients will never walk without assistance again. So that changes life a lot. And about 25% of them will require long-term care. So they no longer will be living at their homes if they were at home before the fracture. And the healthcare cost. About $22 billion is spent for the osteoporosis and related fractures in the United States every year. And I'm not to undermine the breast cancer, but just wanted to compare because that's a more common problem that we hear about and we are more aware of, that we spend about $7 billion in the United States for breast cancer related care. So public health, from the public health perspective, it is really important for the healthcare cost that we have for osteoporosis and related fractures. So, due to the under-recognition, osteoporosis is not treated properly, and because of the decreased awareness, we don't even think about it because of all other competing chronic disease priorities that we have in our patients when we see the older patients. But think about this fact that 10,000 baby boomers are turning 65 every day. That's a fast-growing population who will invariably have some age-related bone loss, which can increase the risk of osteoporosis and fracture. And the number of elderly who are 65 years and older in the United States, there were 34 million in 1998, and by the year 2030, there will be 70 million. So you can see the growth and how osteoporosis and fractures may become a big public health problem, chronic disease problem in these elderly. And the concern for the under-recognition and under-treatment remains. About 20% of the patients, after they have a fragility fracture and they come to the hospital for this, really follow up after their discharge to be treated or to follow up on their fracture or osteoporosis related issues. Only 20% of these patients follow up. Fracture often is the first sign of osteoporosis. So they have already had the consequence, and that's when we find out about osteoporosis. But it should be opposite. We should screen, we should find out, we should try to prevent the fracture. That's not happening yet. Half of the osteoporosis related visits in the nation was seen to be done by primary care physicians, who are mostly family physicians, general internal medicine, sometimes OB-GYNs, or geriatricians. It was about 5% of these patients were seen in 2002 by the PCPs, and in 2008 it became 20%. It's based on the NAMS data set. And most of these patients had high blood pressure, increased cholesterol, increased level of cholesterol, osteoarthritis, diabetes, mostly type 2, depression, And this is like typical older patient that we have. And these are the patients who are seen by primary care physicians, where these patients are also asking for help for their osteoporosis. So it's no longer a specialty disease, it has become a general primary care disease for the older patients, and lack of awareness sometimes that impairs. And the barrier for taking care of osteoporosis by the primary care physicians or geriatricians is that they have to take care of these competing chronic diseases that I just mentioned to you. And they have lack of resources, lack of time, and of course we have this rapidly growing geriatric population and not enough trained specialty care physicians. So this is becoming an issue, and well, we need to have more trained physicians to take care of this. So osteoporosis is a public health problem in the elderly, and about 10 million Americans suffer from osteoporosis right now, and about 34 million are at risk of developing it. More than 2 million fractures in the United States were attributable to osteoporosis in 2005. And as you know, vertebral fractures are the most common fractures. Hip fracture, wrist fractures, these are the most common osteoporosis-related fractures. For women, the incidence of fracture per year exceeds that of the incidence of stroke, myocardial infarction, and breast cancer combined. So you can see how this is a big problem. And in men, the fracture risk is higher than that of prostate cancer. About 1 in 2 Caucasian women more than 50 years of age will experience a fracture in their lifetime, and in 1 in 5 men more than 50 years of age will experience a fracture. So you know that osteoporosis affects both men and women from all races and ethnicities, although we have more data for Caucasian. And what is osteoporosis? By definition, it's a compromised bone strength that increases risk of fracture. So bone strength is characterized by bone density, which we can measure clinically, but there are other qualities that are not yet clinically measurable, like bone qualities. Microarchitecture, influenced by the remodeling, bone turnover, I'll talk about it a little bit, but it's not still very common in clinical practice. Bone mineralization, the other factors that are more difficult to quantify, such as damage accumulation, that are all contributing to the bone strength. So this is what happens. On the left-hand side, as you can see, this is like a normal bone. So there's a trabecular bone and there's cortical bone on the side. And we have, when a fragility fracture happens, that's because we lose bone, both quantitative and qualitative changes takes place. And you see the dark spots on the right side in the trabecular bone area, that's where the mineral was lost. Then when we fall, we fracture our bone without any high impact trauma, and that's called the fragility fracture. It happens because we lose bone density as we get older. And from this chart, you will be able to see how the curve of decreasing bone density kind of follows the same trend despite or regardless our racial and ethnic background. So the top one is for black males, and then the blue one is for Caucasian male, white male, and then we have the black female and white female. Women always have lower bone density than men, but as you can see, the trend of decreasing bone density with age is similar for all of them. So you saw the picture of where the bone mineral losses were showing in the trabecular area, and only 20% of our skeletal mass is trabecular, but they have a greater surface area than the cortical bone, and they provide supporting strength to the ends of the weight-bearing bones. As opposed to this, we have about 80% of our skeletons made of cortical bones, but they're the solid outsides of on the shaft of long bones. There are multiple other bone cells, but most relevant for now in the clinical practice for the bone markers that we measure are related to osteoblasts, which are critical to bone formation. Osteoclasts, they reabsorb the bone, and osteocytes, although we're still finding out about its function, but it is involved in the bone turnover. So this picture kind of tells you the normal bone remodeling cycle. So we have the osteoclasts coming and sort of absorbing the bone or eating up the bone. And then we have osteoblasts that are coming to fill up the area that have been reabsorbed or destroyed by the osteoclast. And this whole process takes about 3 months, and it's called the normal bone modeling or remodeling cycle. Usually when we're younger, the resorption by the osteoclast is equal to the formation by the osteoblast and no change in bone mass. But what happens with aging? As we get older, that's the pathogenesis of age-related bone loss. It is unbalanced remodeling. So the resorption is faster and more than the formation. So what happens is there's a net bone loss. It increases with factors such as inadequate calcium or vitamin D in our bone. After menopause, we lose estrogen in women, just with normal aging, and medications such as steroids. And here's a picture of the normal bone structure on the left side, and on the right side, as you can see, it's osteoporotic bone structure. And this is a picture showing how a bone density done by DEXA scans look like. We usually in the clinical practice measure bone density of spine for lumbar spine between L1 to L4 and the femur or the hip region. And osteoporosis is considered when a T-score from these scans are less than -2.5, or osteopenia, meaning some bone loss but not osteoporotic yet, but risk of that is T-score of between -1 to -2.5. I'm sorry for the busy slide here, but I just wanted to show you what United States Services Task Force say about screening for osteoporosis. They actually have screening recommendations for women. And for men without previous known fractures or secondary causes of osteoporosis, there is no recommendation. The other organizations that have these screening recommendations are the National Osteoporosis Foundation. We do a bone mineral density for screening for osteoporosis in all women who are 65 years or older, or postmenopausal women, even if they are less than 65 years of age, but they have a risk profile, like they have risk factors for osteoporosis. And for men, they say 70 years or older, or men who are 50 to 69 years of age, if they have a risk factor. Now, World Health Organization only have recommendations for women, just like the USPSTF. And they're saying there is indirect evidence that supports screening for 65 years and older, but no direct evidence for widespread screening otherwise. American College of Physicians has a recommendation for men, for older men at high risk and candidate for therapy. So if you think that they can be treated, then you do screening in them. And American College of Gynecology, of course, obstetric and gynecology, they only have recommendation for women, which is bone mineral density for all women who are more than 65 years of age, and postmenopausal women under 65 who have more than one or more risk factors for osteoporosis. And this is a fracture risk assessment tool. It's called FRAX in short, FRAX, and you can Google this. They are based on a geographical location of the country. They take care, or they account for, the lifestyle and the ethnicity and racial background, some of the other risk factors that I'll go to in a second. But it's easy to do online, available on Google search or any other search. And anybody who is in the community can actually calculate their risk by this tool. And this is approved by World Health Organization. You can do it with or without bone mineral density. So even if you do not have access to a DEXA machine or a ability to do bone density, you are able to assess the risk of fracture using this tool. And this is only for men and women who are between 40 and 90 years of age. So it's not valid in people who are less than 40 or more than 90 years of age, but it is also not valid for patients who have been on treatment for osteoporosis, because that changes their risk of fracture. So you need to know their gender, height and weight, and race and ethnicity, if they had a previous fracture, if their parents had a hip fracture, current smoking, yes or no. Alcohol, they ask that if they drink more than 3 or more drinks per day, if they have used glucocorticoids or steroid, mostly oral, for at least 3 months with a 5 milligram dose. And if they had secondary risk of osteoporosis, or like rheumatoid arthritis or diabetes type 1, osteogenesis imperfecta in adults, and untreated hyper or hypothyroidism, and premature menopause if they had it before the age of 45, and chronic malnutrition or other diseases causing malabsorption. So how do we know who are we going to treat? Let's say we do the bone density and they have osteoporosis and we treat. But what if they do not have osteoporosis? We know that we now have talked about the screening tools. If somebody doesn't have bone density, like we said with the FRAX score, we can think about treating, but that happens only if the FRAX score says the probability of a hip fracture in this patient is 3% or more in the United States, or other major fractures, it is more than 20% risk of fracture, then we treat. But what if you have an osteopenic patient? So these are the recommendations from the National Osteoporosis Foundation for treating men or women for osteoporosis. The scenarios are either a history of hip fracture, like if you had a hip fracture when you were older without high impact trauma, so that's a fragility fracture, whether this patient has had a bone density, whether you know by bone density they have a osteoporosis or not, or if you don't even know their FRAX score, that person needs to be treated. By definition, that person has osteoporosis. Other prior fractures are, or a patient with other prior fractures and a T-score of osteopenic range. So a patient has osteopenia on your screening bone density, but they have had a prior fracture, which is considered fragility fracture, then they need to be treated. Height loss is one of the risk factors. So if they had an osteopenic risk factor, osteopenic bone mineral density, and had a height loss of more than 3 inches, it says that means they already have had multiple vertebral compression fractures. So that constitutes a other prior fracture, and that person needs to be treated. And of course, if the person has a T-score of osteoporotic range, then you treat them. You also treat them if they have osteopenic bone density and yet they have a secondary cause of risk of fracture. For example, they are on chronic steroid use, or for men who are androgen deprived because of prostate cancer or other diseases. Or if they have osteopenic bone density, yet their FRAX score says that for the United States and for their racial background, their probability of hip fracture in the next 10 years is more than 3%, or other major fractures is more than 20%. These are the recommendations for treating osteoporosis in men and women by the National Osteoporosis Foundation. So what do we treat with? Well, as you know, bisphosphonates are the most common medications or first-line agents that we treat for, and this has been out there in the market for the longest as well. And there are some oral therapies. There are some weekly and monthly regimens. Most commonly known are the alendronates, but there is risedronates and abandonates. These are oral. And then there is IV forms of bisphosphonate, which is zoledronic acid, and you give them intravenously once a year if they are able to tolerate. But be cautious in patients who have renal insufficiency when you use zoledronic acid. Teriparatide is a recombinant human PTH, which is given subcutaneously as an injection every day in patients, but these are usually given in patients who have had anti-resorptive therapy like bisphosphonate for about 2 years, and then if they did not improve their bone density, then we give them this to improve their bone formation. It actually is an anabolic agent and it increases bone formation, but it is not recommended to give it for more than 2 years in patients. It also is contraindicated in patients who has had a personal history of cancer. Denosumab is another medication that is similar to bisphosphonate in terms of their nature of function, which is anti-resorptive mechanism of action. But these are humanized monoclonal antibody. It's given under the skin once every 6 months. While we treat people or patients with these type of medications, whatever they may be a candidate for, we have to continue the calcium and vitamin D supplements. And usually it is calcium in these older patients between 12 to 1500 milligram and vitamin D 800 to 1000 units, international units daily. But given that the vitamin D level is normal, so we have to check for a baseline vitamin D level first. There are other agents which are not used as a first-line agent and may not be appropriate for our older patients either, like SERM, the selective estrogen receptor modulator, raloxifene, which is not commonly used in our older patients because of its increased risk of DVT, or deep vein thrombosis. Estrogen and progesterone also not encouraged due to the increased risk of breast cancer, stroke, DVT, and coronary diseases in patients. Testosterone, if hypogonadism is the cause of osteoporosis in a man, that's when we can use testosterone. But I highly recommend to talk to the specialist before using any of these agents. So the calcium and vitamin D, just wanted to talk a little bit about the different formulations, because we do have patients who come in and will tell you that they are not tolerating their calcium and vitamin D supplements. It can be just because of the formulation that are available in the market. So the calcium can come in carbonate or citrate forms. You also have to think about how much they're taking with their diet. So for example, an 8-ounce glass of milk will provide about 300 milligram of calcium. So if someone needs between 1,000 to 1,500 milligram of 1,200 or 1,200 to 1,500 milligram of calcium, and they already drink 2 glasses of milk a day, then you need to give them that 1,000 or 1,200 minus 600, because they're already getting that from their diet. So you have to incorporate the amount they're taking from the diet. And then some patients will tolerate the carbonate formulation fine, and some of them will have some stomach irritation, so you can also suggest citrate formulation for those patients. And carbonate formulation is usually recommended with meal, and the citrate in the fasting state to be taken by the patients. And vitamin D, screen if the patient has normal vitamin D, which we check with the 25-hydroxy vitamin D total. For patients with compromised skeletal health, meaning if they have osteoporosis or have had fractures, they need to have a vitamin D level of 30 nanogram per dl or more. So if they did not have that, then you can provide them with a prescription of ergocalciferol or cholecalciferol. Either D2 or D3 is okay for the supplementation, and you can give them on a daily dose is required as 800 to 1,000 international unit. But if they have less than 30 nanogram per dl level, then we usually give them a prescription of 50,000 units, either of ergo and cholecalciferol, and Q every weekly between 8 to 12 weeks, depending on the patients. So let's talk about the fracture outcomes and the side effects of this medication that I just told you we use to treat osteoporosis. So for bisphosphonates, it reduces risk of vertebral and non-vertebral and hip fractures, except for ibantonate, which reduces the risk of vertebral fractures. For teriparatide, it reduces both risk of both vertebral and non-vertebral fractures. And for denosumab, it also reduces both vertebral and non-vertebral and hip fractures. But look at the side effects, and you may be more familiar about these from TV ads. Bisphosphonates, most commonly you'll hear gastrointestinal irritation, reflux, heartburn. Sometimes the patients will come and tell you they also have myalgia or arthralgia. They will come and tell you, I have muscle pain or body ache or joint pain. Like I said, for the IV formation, you need to think about the renal insufficiency because it can impair renal function. Atypical fracture, that's the fracture of the usually femur shaft or mid-thigh fracture that happens from long-term use of bisphosphonates. Not very common, but it can happen. Osteonecrosis of the jaw also, when it happens, it's really bad. And these are the two side effects that are very commonly known to the patients as well for the media services. So you need to be aware of that and have to address that before you start treatment. Teriparatide, it increases the risk of osteosarcoma observed in rats only because the study was done in animals. So they contraindicated this medication for patients who have had any history of cancer, but there was no human study done. And for denosumab, because it's an under subcutaneous injection, it can cause dermatitis. It can cause hypocalcemia, so it lowers the serum calcium level. Osteonecrosis of the jaw, like the bisphosphonates, because these are both anti-resorptive medication, are common. Pancreatitis can also be one of the side effects of denosumab. So when these side effects happen, is this when we call it treatment failure? And if this happens, then where do we go next? So a patient has a side effect from a medication, what do we do? I already talked to you about these side effects. So when the side effects happen and if they have unimproved bone mineral density, even after the treatment, and it's mostly we're talking about the bisphosphonates. So if you did not have improved bone mineral density, or if the patient has had fracture while being on the treatment, what do? That is considered the treatment failure. You can switch to other agents. For example, I told you the teriparatide, which you can use up to 2 years to improve bone formation. And this is when we can use bone turnover markers as a monitoring tool to see where the patient was and where the patient will be in a year when we switch medications or we stop medication. So another way to improve the bone health is by stopping the medication, and it's called drug holiday. And you monitor bone density in 1 to 2 years, and also monitor bone markers. And the bone turnover markers, as I showed you with the normal bone remodeling cycle, that the osteoclast comes and then resorb the bone, and then the osteoblast comes and forms the bone. We have bone turnover markers, and I'll talk about that later. The bone turnover markers are usually suppressed. Because it is anti-resorptive, it slows down bone resorption. And when it slows down bone resorption, bone formation and resorption are in a cycle, in a loop. So one gives feedback to the other. As osteoclasts finish their work for resorption, it sends a feedback to the osteoblast for formation. But with this medication, when it slows down the resorption, there's not enough feedback for formation, so the formation slows down. And if this is the case, when you see it with the marker, teriparatide will be an option. But what if that is not an option? That's when you have to stop. If it is all suppressed, you need to let the markers come up again, the bone metabolism to come to close to normal state again. So you stop or hold the medication for a year. You monitor with bone density and markers, and that's called the drug holiday. So when we say the bone density did not improve, what does that mean? It could be stable. So every single bone density machine has a variation range, which is considered normal for that machine. So the significant change will be considered if it goes beyond that range, and it's maintained with the quality assurance mechanism that each site has, and they have a QA scan every morning, and then they see the drift in that QA, and according to the drift they decide what would be a significant change. So if it is more than 2.5% change, maybe that's significant for that site. That is why it is important to also continue having the same bone densities at the same place using the same machine. Sometimes it's not possible. So, but usually these significant ranges are between 1.5 to 2 or 2.5. So if it is more than 2% change, then you think about and you look at the other clinical scenarios and history of fracture, and you think about what is significant. But most of the time, if it is at the same place, then you can go with the significant change for that site, and if it is beyond that, then you think if it has been improved or not. And also you look at the bone turnover markers, and if they are suppressed, then usually between 35 to 50% suppression. But if you don't know the baseline, it's hard to know what is 35 to 50% suppression, and we'll talk about that in a little bit. So you monitor with that, and if you see the significant change, then you think the medication is working, and if the markers are suppressed, you think the medication is working, and decide what's the next step. Other way of improving osteoporosis care is by identifying the case and follow up. As I mentioned earlier, that it is undertreated and under-recognized. The one way to do it is now nationwide. We have this, actually around the world, we have this movement which is called Fracture Liaison Services. And what happens is you have this dedicated group of people, including it's an interdisciplinary team. It's the orthopedic surgeons, it's the primary care physicians, geriatricians, endocrinologists working together to find cases when a patient comes with a fracture to the hospital. And then you talk to the patient, educate them, you try to investigate or screen them, or if they had a fragility fracture, they're already diagnosed as osteoporosis. Then you link them to the primary care physician and make sure that they have outpatient follow-up, and they come back for bone density testing or other like bone turnover marker testing, and to make sure that they are doing everything else that needs to be done. The results actually showed improved follow-up and prevention and increased continuity and quality of care. What it did is increase case identification. So it increased the diagnosis, and of course more patients got treatment when they got diagnosed. It has improved bone mineral density testing, screening testing, from 3% to 45%. And the liaison between the orthopedics and the discharge destination healthcare team, including the primary care physicians, improve the provider awareness and treatment for their patient, and improve the treatment with documentation of bone mineral density and what other clinical measurements they could have had, like the bone turnover markers. And of course, fracture prevention algorithm is there now available based on the FLS, and you can look it up. There is no information on bone turnover marker from these fracture liaison services yet, but the National Bone Health Alliance is now working on this and will hopefully have a guideline for that. But most important thing to remember is it's not done by one person. It is an interprofessional teamwork together that is improving osteoporosis care through these fracture liaison services. So just wanted to give you a little bit of idea about the bone formation and resorption markers. So usually there are two types. We very commonly use bone alkaline phosphatase, but P1NP or the procollagen type 1 amino terminal propeptides are also a robust formation marker that you can check in the serum. Osteocalcin is usually a turnover marker, so it gives you the rate of bone turnover. And the resorption markers in the serum is C-terminal cross-linking telepeptide in short of type 1 collagens, which in short is called CTX. Or in the urine is the N-terminal peptide, which is in short called NTX. Usually is the best if you collect them as the second void sample in the morning, but if you are monitoring the same patient, there are literatures out there that says that just for monitoring in the same person, it is okay to use the spot urine. So when you check these bone turnover markers, and as I told you, if they're suppressed, that's an additional information that you have with bone density or fracture history to find out if your patient is getting into treatment failure or their treatment is going well and they're improving on their bone health. So again, this is not a standard medical practice yet, but this is in practice now by some specialties. There is a working group that's working hard on getting a clinical guideline for this. Wanted to end with a case, so to see how we're going to think when we have a patient with osteoporosis. Based on what we have learned today, how do we screen and who needs to be treated, and how do we know if it's a treatment failure, or how do we proceed to the future based on their history of treatment. I think this case will be very useful for us to discuss. So this is also a real case. 85-year-old Caucasian female, her BMI is 21, so as you can see, it's a very tiny person, lost about 4 inches height since in her 30s. So you can see, we talked about the risk factors of vertebral fracture when a person has decreased height. And she does not have any personal history of cancer or any previous fracture or any other known secondary risk of osteoporosis. No family history of osteoporosis or hip fractures in parents. She is a former smoker but not current smoker, social drinker, so she doesn't drink 3 or more alcohol servings per day. She does exercise regularly, weight bearing, and has a history of osteoporosis though, and has been treated with bisphosphonates for about 14 years without much improvement in bone mineral density. And these are following her DEXA, but I just wanted to go over these points a little bit with you guys. So she's a Caucasian person, which is with the ethnic and racial background, that's a risk factor. Her weight with a BMI of 21, that is a risk factor. Her height loss with 4 inches height loss, that's significant, and she probably has had multiple vertebral compression fractures, which we don't know about because oftentimes the vertebral fractures are painless. It could be very painful, but it can be painless as well. And incidentally, you'll find out from a chest x-ray for the person when you needed to do that for something else, like finding out pneumonia. And she has been on bisphosphonate for 14 years. Now that we know the long-term effects of bisphosphonates, and it's usually recommended not to continue that after 5 years unless necessary based on the measurements that we talked about. So she comes in to find out whether she heard about the side effects of bisphosphonates and that she has been on it for so long. Now she wants to know what to do. So her bone density shows in the femoral neck, it was T-score of -2.1. in 1997. So what was it? It's osteopenic, not osteoporotic. Remember, osteoporotic has to be minus 2.5 or less. Then in 2006, it's minus 2.2. 2008, it's minus 2.1, and in 2010, it's minus 2. And the change from baseline from the latest one was actually 2% higher, but it's still not osteoporotic range. So remember the treatment guidelines that we have now. Now this has been going on for a long time for her, and at that time the treatment guidelines were not as up to date as we have now. And we now know more about the side effects of the medications that has been out there in the market. So we now recommend to be off bisphosphonate after 5 years, and also we check bone densities, and we know that a patient with osteopenia and risk factors we will treat. She does have risk factors with osteopenia. So this patient has had bone markers done. So her urine NTX is 18, and if we go back to the markers, you will see the normal ranges for premenopausal, we don't even have menopausal ranges yet, is between 4 and 64. Hers is 18. Very low, so I assume it's suppressed, and it's a side effect, not a side effect, it's a sign that the bisphosphonates were working. P1NP is 11, and for that the ranges is between 20 and 108. And her vitamin D, calcium, PTH, and magnesium and phosphate were all within normal range. So what do you do? So our patient has had osteopenia, and we know that in osteopenic patients, if they have FRAX score indicating treatment, we can treat. But FRAX would not be valid in our patient because her fracture risk has changed with treatment with bisphosphonate. But she does have risk factors. She has 4 inches height loss, has been on bisphosphonate for more than 5 years, which is an indication to reassess and think about changing or drug holiday. Her bone markers are suppressed. And not only that, it shows that the bisphosphonate is working, but it's actually very low. So I think with all of these indications, we stop bisphosphonate, we start a drug holiday and monitor for a year. You could give her the teriparatide, which is an injection subcutaneously a day, and see how her markers come up. But she being very active, and if you discuss this risk and benefit, my patient actually wanted to opt for drug holiday and come back in a year to reassess with bone density and bone markers. But in the meantime, you have to continue the calcium and vitamin D supplementation, and of course the weight-bearing exercise. That is very important. So how do we prevent? Prevention is actually very important to start during young age for osteoporosis, although it is a disease of old age. And look at this curve. The peak bone mass takes place between 20 and 30, or around when we were in our 20s. So you see the curve going down as we get menopausal or older for men and lose bone. And you have seen the decrease in bone density with age before. But the important thing about this graph is that you see the solid line and the dotted line. The solid line is the full genetic potential of having a high peak bone mass around age 20 for the people. And even if they lose bone, they will lose less because they already gained a good bone health. But if you don't gain good bone health in your early age, it's difficult to keep up and not lose and become osteoporotic later. So the prevention starts very early during childhood to have good nutrition. And of course, we also inherit some of our bone health from our mothers. So the mothers need to be well nourished as well when they're pregnant. So how do we prevent? Besides gaining a good peak bone mass in our early life, when we're older, continue the weight-bearing exercise. And the people from literature, it says that people who have been exercising all their lifetime, not people who just exercise in young age and then stopped, or not people who started in middle age and continued, or not people who started in old age. Best if you continued some kind of weight-bearing exercise all your life. It is recommended if you're healthy enough and be able to exercise, to do weight-bearing exercise between 2.4 to 4 hours per week at the moderate to severe intensity, which is about walking 3.5 miles per hour. And of course, continue the calcium and vitamin D supplementation. And the other factors to consider to improve bone health is fall prevention, of course, to prevent a fracture, improve balance and gait with physical therapy and occupational therapy, smoking cessation, avoid risk level alcohol use, and avoid flexion in patients with risk of history of vertebral fracture, because flexing more than 30 to 45 degrees, it increases pressure and fracture risk in patients. And of course, it's good to have a fracture liaison services in place in your hospital, and that will network within the clinic and the group of providers with an interdisciplinary team. And this is a secondary prevention of fracture. So we have now talked about what is osteoporosis, why is it important, and its importance as a public health problem in our older patients. How do we assess for this, and who should be treated, and prevention. So the take-home message from all of this is that osteoporosis is a progressive and chronic metabolic bone disease. It decreases bone density and deteriorates bone structure that increases risk of fracture. The clinical diagnosis remains as bone density T-score of -2.5 or less, and the prevention and treatment, we talked about that we need to start preventing really during our childhood, and with comprehensive assessment and diagnosis, we can treat people with individualized approach depending on what they really need based on their treatment history, whether they were treated or not in the past.